Okie dokie. So we're going to continue our talks on dermatology. So first thing we'll hit up is going to be contact dermatitis. So we know that this is going to be it could be an acute dermatitis, could be a chronic thing. Usually it's going to be related to skin contact with either a chemical or an allergen, something the skin just does not like. It's causing this inflammation. A lot of things can be like soaps, detergents, could be a brand new deodorant that you didn't realize when you bought it that's going to cause you irritation. Now you have to go buy a new deodorant. Not that I would know about that. Sometimes you'll see cases like poison ivy, poison oak, things like that, but all of which are causing this inflammation. So as far as treatment options go, typically for just localized involvement, for things that are not very widespread, you can get away with things like topical hydrocortisone. We talked a lot about that in the last class. You could use other topical steroids, but typically hydrocortisone is going to be the nice go-to one because it's cheap, it's widely available. You don't really run into a lot of systemic side effects if you're using kind of over-the-counter varieties because they're just not that concentrated. We already talked about different dosage forms of which ones are going to be better for kind of weeping lesions versus which ones are really dry. In some really severe cases or very widespread disease, and this kind of goes along with a lot of dermatology, for very wide progressive disease, you may need oral products just because you need to have systemically administered drugs, because otherwise if you're trying to apply the entire body with a topical product, you can run some issues there, and it's very difficult for a patient to keep up with that. So typically you don't see a lot of systemic corticosteroid therapy being used, but certainly if it's a kind of chronic, very extensive or very severe condition, you may need systemic or orally administered steroids. There's just some pictures of some contact dermatitis. Like you can tell, like on this upper left-hand picture, it's probably some tape or something that was applied to the patient. They're just kind of, the skin's just kind of angry with it, you know. So you got to apply some topical steroids, and it'll kind of deal with a lot of the inflammation. Some other options you may see for different inflammatory conditions. So some astringents. These are typically agents that are going to have kind of a drying effect on the secretions or on dry mucus secretions. You'll have shrinking of some skin cells and things like that. So calamine, zinc oxide, again, these are pretty commonly available over-the-counter agents, can be used for some of these and kind of help in reducing some of this inflammation. As far as, we won't talk too much about oral antihistamines, we'll have a different section where we talk more about those, but they may be utilized systemically to help with some of the itching and things like that. But they also have some side effects associated with them. So anytime you're administering anything systemically, you're more likely to run into side effects. But we'll talk more about those in a later date. There are some topical antihistamines, things like diphenhydramine or Benadryl, that are available, but they're kind of questionable efficacy. Some people may even have some irritations from those products too. So we routinely recommend a lot of those. Moving on, we'll then have impetigo, which this is going to be more of a infectious disease kind of disease state. Most often, these are going to be caused by your typical gram-positive skin flora, so things like staphylococci and streptococci. Those are your most common ones. You'll see that, again, with more involved cases or more severe cases, this is where systemic medications are going to be utilized. So in a lot of cases, especially if you're just thinking like, MSSA, if you know that your community rates of MRSA are not very high, and again, a lot of that's based on cultures that you've pulled from your, either the organization that you're at with like an antibiogram or other data, you can get away with something like that has just MSSA coverage. So things like dicloxacillin, which we talked about being an anti-staphylococcal penicillin. We talked about cephalaxin, which is what generation cephalosporin? Yeah, it's a first-generation cephalosporins. Again, remember, as cephalosporins go forward in generation, you're going to lose more of that gram-positive, so cephalaxin is still going to be useful for that MSSA. It'll still cover for that. Typically for 7 days, and you'll see that for just the more involved disease, it's going to be a little bit more efficacious than just your topically applied antibiotics. If you are concerned about MRSA, clindamycin is typically going to be a good one to go with. If you were having high rates of clinda-resistant MRSA, then potentially something like sulfamethoxazole trimethoprim or Bactrim might be a good option there. Right, Bactrim just being the brand name for that one. If you can get with topical drugs, if it's kind of localized disease, you can use a couple different agents, one being mupirocin, otherwise known as Bactroban. This is working by inhibiting some protein synthesis of the bacteria by interfering with this tRNA. You will oftentimes see, or at least where I've seen Bactroban used most frequently, is for people who are nasal carriers of MRSA. So if you ever go into the hospital and they do nasal swabs for MRSA, that's typically what they'll end up applying is some Bactroban ointment. But you can also use it from other, impetigo and other kind of gram-positive skin infections. We also have this rotapamulin, which inhibits this 50S ribosome to inhibit bacterial growth. Again, with both of these products, you don't see a ton of systemic absorption because they are being applied locally. They don't really absorb all that well, so you really don't run into a whole lot of drug-drug interactions or anything like that. Anytime you're applying something topically, you do run the risk of then the patient having an allergy to it or having some kind of irritation from. So just always keep that in mind. Keep in mind that when you're treating impetigo, you want to make sure that it is, you don't want to just think it's like some kind of dermatitis and you're giving steroids for that, because that will, again, steroids have an immunosuppressant type of effect, and so that can actually make the bacterial infection worse. So you want to make sure that you kind of rule out bacterial causes before you just start applying topical steroids, because that may actually make the situation worse in some cases. Does that make sense? Okay. Moving on, then we have acne, which would probably be a pretty common thing popping up, especially in family practice and whatnot. We know it's caused by a lot of different factors, but there's kind of 4 main things that go into the pathophysiology for acne. One is going to be this increased sebum production. It's that fatty lubricant that's producing the sebaceous glands in the skin. You have too much of that, it's kind of clogging up a lot of these pores. You will end up having this abnormal keratinization within the pilosebaceous canal, and I'll show you some pictures of that in just a second. Once that happens, then you're going to end up having some bacterial colonization, and specifically you're going to have this Propionibacterium acnes, and that's the main bacteria that we're going to be focusing on with some of our antibiotics we'll use for this. So it's, again, it's really important that whatever drugs you're applying have activity against that bacteria. If the helicopter gets too loud, let me know and I'll stop talking. And then after that, once you have all this bacteria kind of forming there, then you're going to have the body producing an inflammatory response to that, and that's where you get a lot of the inflammation from. There's lots of data saying that kind of debunk a lot of things like diet, psychological stress, cleanliness, and all that do not contribute to it. Your mileage might vary with that. There could be some coincidental, things happening with your patient where they think, oh, I ate too much pizza, now I have acne. Probably not, but who knows. But we do know that sex hormones do have an effect there, so like things like androgens. Okay, I'm going to go ahead and pause it for a second. That's fine. Okay, so anywho, but we do know sex hormones are going to have an effect here, so this will be important for some of our mechanisms of actions of some medications a little bit. So certainly androgens will activate acne. Have you guys ever seen someone who does like steroids, like anabolic steroids to get big and muscly? They usually have acne, roid rage, but they usually have acne along with their back knees is pretty bad. And so again, that can happen to females, can happen to males as well, but it's usually from the androgen effect you're going to see that. So in a lot of cases, some patients may actually have improvements in their acne if they're on estrogen-containing products, like things like oral contraception. So sometimes people will be on that. It's kind of a nice positive side effect of those medications. Just some pictures of acne. Okay, so again, there's certainly some environmental factors that can help to kind of move along the pathophysiology of this. So certainly heat and humidity can help to induce some of these comedones, like especially pressure or friction. So if you have like helmets on or shoulder pads and things like that, especially with lots of hormonal teenagers and things like that, you see a lot of acne popping up in places like that. If you have excessive scrubbing or washing, can kind of irritate the skin. Depends on the season as well. Patients may have some issues there. Now there probably is some degree of credence to stress inducing some degree of acne, but a lot of it has to do with just the fact that you're in a more stressed state and you're producing a lot of glucocorticoids. That may lead you to be more prone to developing acne. We'll see that glucocorticoids in general can help to induce that as well. Similar to how you see with anabolic steroids, glucocorticoids can do very similar things. So like we mentioned, you see a lot of the proliferation of this Propionibacterium acnes, and this T cell response is what leads to a lot of this inflammation. So you can kind of see a couple of different varieties. There may be a non-inflammatory versus an inflammatory kind. We'll see that they're mostly going to be treated the same regardless. And here's a nice picture kind of showing the pathophysiology here. You see the pilosebaceous duct being basically clogged up, and then you just have all these bacteria start to kind of generate in that area, and then you have the inflammation kind of occurring in this kind of later stage, and then you get a nice big zit out of it. So there's no known cure for acne. Oh, go ahead. Oh, I'm sorry, that was triglycerides and fatty acids. Yep. Thank you for pointing that out. So as far as the cure goes, we don't really have one, but we do have medications that will help to reduce a lot of the severity. You will see that one patient or one therapy is not going to be perfect for every single patient. So it's really more of an art than science, and it's really highly individualized for your particular patient, based on a lot of different factors, which we'll talk about. Again, treatment can be preventative because there's not a whole lot you can do for existing lesions as they are, but you can help to prevent them from getting worse in the future. And then the other thing to note is that it takes time for these to really show their efficaciousness, so make sure that you're giving at least 1 to 2 months before you start modifying treatment, before you say something is really not working well. So again, because this is a chronic disease, we wanted to do early aggressive treatment if possible, because this helps to prevent scar formation and more disfigurement. And then it will focus on more maintenance therapy of the disease state. You want to reduce the number and severity of the lesions, slow progression, and hopefully decrease a lot of this kind of long-term disfigurement and psychological suffering they might be experiencing. There can be cases of drug-induced acne, so there's a couple of different medications that this is kind of more common with. So certainly systemic corticosteroids are one of the big ones. So again, when we talk about corticosteroids being administered systemically, either orally or IV, lots of side effects pop up from this, but acne can be one of them. A lot of it may have to do with their immunosuppressant type of effects, because it allows more proliferation of those bacteria. You don't see quite so much with hydrocortisone, but certainly after long-term therapy, for someone who may be on, say, a chronic inflammatory disease, they're on these corticosteroids for a while, this could be a problem that pops up. And then the other thing is that when you remove the steroids very quickly, all of a sudden you can end up having this kind of worsening of the effects, because now all of a sudden the inflammation, the body can start to produce that immune response again, so they get an initial worsening as their immune response pops up and they get more inflammation right there. Kind of like a rebound effect, absolutely. Certain anti-epileptics, so certain seizure medications, as we'll talk about later in the class, can do this. Tuberculostatics, or things for tuberculosis, can do this. And also lithium, which is a drug you'll see commonly for bipolar disorder. So treatment, we really want to be targeting this microcomedone, eliminating that occlusion of the follicle, so that way you prevent the bacteria from really proliferating in the first place. We're going to use a combination of pharmacologic and non-pharmacologic therapy, although I'll be focusing on the more pharmacologic. And oftentimes when you use multiple medications, you're going to be targeting different mechanisms of action. It doesn't make sense to do 2 medications that do the same thing. We want to have more synergy by using multiple mechanisms here. And then you want to target multiple pathogenic steps. Okay, and we'll talk about that in a second. Typically for more mild to moderate disease, you're going to use topical therapy, because again, it limits the amount of systemic side effects you can have. For moderate to severe, you're going to see more systemic therapy. So we'll talk about the stepwise approach you can see there. So this slide just kind of organizes the drugs based on what they're doing. We'll go over these in more detail as we talk about the specific medications. So look at non-pharmacologic therapy. Cleansing is important to do it right. You don't want to do it too much, and you don't want to do it too little. Using surfactant systems like soaps and things like that can help to disperse and remove a lot of those fat and oils from the skin surface to help prevent that plugging from occurring in the beginning. But of course, if you clean too much, what happens? You dry it out, your face gets all inflamed. It can be more likely to have the acne pop up there as well. So again, soaps are not always the best products, because again, once they're rinsed off, they're not really providing any further help at that point, right? You're just allowing more of the oils and fats to kind of come back. Not only that, but you see that some of the soaps, which typically have a higher pH, so again above 7, because they're more basic, will end up degrading some of the activity of some of these agents, right? And some patients might even have some dermatitis from certain types of soaps and things like that. So important, once they find one, make sure that they it's not irritating to them, and make sure they don't do it too frequently. So maybe like twice a day. You don't want to do it like every single hour, because otherwise their face is going to be just super inflamed, or wherever it happens to be at. Yes.
What do you mean by surfactant system?
So typically, a lot of your soaps are working bases kind of like a surfactant. They're kind of high pH, so they're basic, and they can kind of help get rid of all of those fats and oils. That's why bases are so good at getting rid of those, because they can kind of help disperse a lot of those fats and oils. So you guys ever seen like yeah, it kind of gets rid of the grease. Have you guys ever seen like Fight Club when they're making a bunch of soap out of human fat? Yeah, think about that. That's your homework. Go watch Fight Club. Just kidding. Anywho, so again, topical therapy is really only going to work where it's being applied to. So And again, it needs to be applied to the entire affected area, which is why if it's really extensive disease, systemic therapy might be better for the patient. You will see that a lot of them will cause irritation of the skin. So a lot of them are going to be causing very predictable side effects, most of which are going to be irritation. Some patients can't deal with this, so it may lead to discontinuation, will certainly lead to decreased compliance in a lot of cases. And so in general, you want to start with lower strength products, and then gradually increase strength and concentration as you go. And then you want to consider using non-alcoholic solutions. Why is that? Very drying. Like we said in the last time, that anything with like alcohol in it is going to be very drying to the skin. So again, this is another slide kind of showing how the different drugs are going to be fitting in with the different pathogenic steps of developing acne. We'll go into more detail with these with the individual drugs. First one, I'm kind of going to go in kind of degree of complexity, or kind of the stepwise approach you're going to be using. First one's going to be benzoyl peroxide. Who's ever used benzoyl peroxide as a young teen, right? Everyone's been kind of hormonal at some point in their life, I imagine. Benzoyl peroxide is probably very commonly available products over the counter. You can get this and utilize it. So this is going to work by penetrating that stratum corneum unchanged, and then it gets actually converted over into benzoic acid. Benzoic acid itself actually has activity against the bacteria that are being proliferating in the follicle. You'll also see some of this peeling and comedolytic effect, so it helps actually get rid of the microcomedones that are forming as well, due to kind of the astringent kind of nature to them. As we mentioned, you want to start with a low concentration, say something like 2.5% once daily, and then as they're tolerating it, you want to start to increase the strength or the frequency. Frequently, you'll find in combination with certain antibiotics, so things like erythromycin, clindamycin can be seen with this. And really, irritation of the skin is going to be one of the biggest side effects you're going to see, but they can also bleach hair, can bleach clothes. So it's definitely something you want to let your patients know about, especially if they're having applied to the trunk, anywhere near the hairline, things like that. They should be aware of that since they can cause some bleaching. Potentially, if they're already irritated, we'll kind of talk about sun exposure in just a little bit with some of the other medications. But if they're already irritated, you don't really get photosensitivity from it necessarily, but certainly the skin can be more irritated. Yeah. Another drug that's working similar to benzoic acid is going to be this azelaic acid. It's kind of a straight chain dicarboxylic acid. And we don't know quite how it works fully, but it's probably having to do a lot similar to benzoyl peroxide with its antimicrobial activity. And then also it's thought to inhibit the conversion from testosterone to dihydrotestosterone. Oftentimes that gets abbreviated as DHT, and dihydrotestosterone is actually a more potent androgen than testosterone is. So dihydrotestosterone is actually a more potent androgen, can cause more acne than testosterone itself. So again, very similar to benzoyl peroxide, you're going to start once daily, then you can increase up to twice daily. And again, mild skin irritation and dryness is probably going to be the biggest side effect you see here, but not really in the bleaching. Again, you should be giving these drugs enough time to really work. So again, 6 to 8 weeks or so, really before you can assess full therapy or full efficacy. Then moving on, we have our topical retinoids. So most of these are kind of based off of retinoic acid, otherwise known as tretinoin, and this is an acid form of vitamin A. And so this is another. Has anyone ever seen Retin A being used? Yeah, actually, it was kind of funny because one time we went on a cruise to the Bahamas. You can buy Retin A over the counter over there in Nassau. My wife was really excited about it, and I was like, what's the big deal? But anyway, so the mechanism, again, is not going to be completely understood, but it helps to, what it's thought to do is to help with abnormal follicular keratinization, so it can help with that comedone formation, help to reduce some of the bacterial counts, and also reduce some of this inflammation. And so typically this will end up being first line for non-inflammatory acne, and then you'll oftentimes see it combined with other agents as well. And we're going to see a lot of other products that are kind of based off of this, that are kind of derivatives of it. Also, it can be useful for things like wrinkles and dyspigmentation as well. So the wrinkles thing is what my wife is really all about, even though she doesn't have any. So whatever. As far as adverse effects go, again, skin irritation is going to be a big thing with these agents. Erythema, desquamation of the skin, so you end up seeing some skin kind of peeling off, burning and stinging. So you will typically see that the body kind of gets tolerant to these effects over time, so it will typically get better and can be inhibited by using things like emollient. So if you use Aquaphor or any kind of moisturizer, things like that can help with it. These, on the other hand, will cause photosensitivity and can lead to severe sunburn to the applied areas. It's important they're using high SPF sunscreen over the areas. Make sure they're covering up, things like that. Otherwise, it can get pretty bad sunburn. And then you also want to avoid these agents during pregnancy. So messing with vitamin A during pregnancy is a no-go. We'll see a lot of these can lead to, especially systemically administered vitamin A derivatives, can lead to some pretty severe teratogenicity. So avoid these in pregnancy. Tretinoin itself is actually photolabile, which means that when it's presented to sunlight, it can be degraded. So you actually want to apply this one nightly. And then if you were to combine it with benzoyl peroxide, it can actually inactivate it. So it's important to let your patients know that, hey, if you're going to use both these products, maybe do the benzoyl peroxide first before you go to bed, make sure it's washed off for a while, and then apply the tretinoin afterwards. Otherwise, if you did it backwards, it would actually inactivate the tretinoin, right? We're going to see with some of these other agents, they're actually more stable chemically speaking, and so they'll actually be able to be used with either in the sunlight or with benzoyl peroxide. So a couple of different varieties, things like adapalene. Again, this one's going to be better stable in sunlight, stable with benzoyl peroxide. Tends to be a little less irritating, so that could be one option. You have this tazarotene. This is actually a third generation retinoid. Can be used for more severe acne and then psoriasis as well, which we'll talk more about psoriasis a little bit later. And then this one you can actually see combined with topical steroids to help reduce skin irritation. So we're kind of getting more kind of stronger agents that are better for more kind of severe disease. Alitretinoin is another derivative. This is actually utilized for Kaposi sarcoma, which is a complication of kind of end-stage AIDS. You may have seen some patients. And this bexarotene can actually be used for T-cell lymphoma. So you kind of see some different uses for these retinoic acid derivatives. There's a couple of different topical antibiotics for acne, and so these are going to be useful against specifically that P. acnes that we're trying to target here. So things like clindamycin is going to be good coverage for this, topical erythromycin. You can utilize sulfacetamide, and then also metronidazole. We saw metronidazole isn't really usually good for a lot of gram-positives, but it does have anaerobic coverage, and so that would be useful for that. So when topical treatment isn't enough, then what are we going to do? Well, then we got to move over to systemic therapy, right? So this is where we can start to see some of our systemic retinoids being used. And so one of the big ones here is going to be Accutane or isotretinoin. Anyone heard of this drug before? Okay. So this is it's a very potent drug. It's very good for acne, but it has a lot of side effects and has a lot of hoops you have to jump through in order to use it. So it's not something you're going to be prescribing just kind of willy-nilly. Takes a while for it to work, and is really going to be contraindicated in pregnancy and breastfeeding. And actually, men who are using it should avoid having unprotected sex as well, because again, they worry about having issues if they were to get someone pregnant while they're being on it. And so they actually have this system called iPledge, which is actually the FDA can mandate certain they call it risk evaluation and management strategies, or REMS, for different drugs that have very particular severe side effects. And this is actually one of them. It's called iPledge, where basically the doctor has to be signed up through it, or the provider has to be signed up for it, the pharmacy has to be signed up through it, and then the patient actually has to be signed up through it as well, right? And so when if I were to fill this at a CVS, like it would ask me like, okay, are you actually signed up for the program? Sign in. Is your patient, have they had the appropriate pregnancy test to show they're not being pregnant? Have they been educated to use backup contraception X, Y, and Z to make sure that they don't want anyone getting pregnant while being exposed to isotretinoin? So very, very serious. And so this iPledge program is one of those things you have to do in order to help prevent those problems from popping up. So similar to other retinoids, you're going to see dermatitis from this. There's erythema, pruritus, scaling that can occur. Because this is systemically administered, you have the potential for it to show up all over the body, depending on the dose and how susceptible the patient is to it. Photophobia, so it can be certainly more sensitive to sunlight. You even see things like brittle nails and alopecia, all because you're kind of monkeying around with vitamin A in the body. Increase in serum lipids as well, so you may have some issues if your patients have kind of uncontrolled hyperlipidemia. And then you really want to look also for signs of developing depression. So kind of having some, patients might be depressed from their acne as it is, but you can actually end up seeing worsening depression in some of your patients who are on this. It can actually have some CNS effects as well. So this is why we really hold off on these drugs until really they've failed all the topical therapy and they really need something more severe or more efficacious for more severe disease. You can also utilize systemic antibiotics for more extensive and difficult to treat disease. You can see things like your tetracyclines being used pretty frequently. Do you remember who we don't want to use tetracyclines in? Kids, that's an A, and then who else? Yeah, pregnant women as well, absolutely. So tetracycline, doxycycline, minocycline are very safe and effective, and they're pretty inexpensive. And so usually, you see kind of your adolescents to young adults will be kind of your prime market for this, as long as they're not going to get pregnant. And then even trimethoprim, sulfacetamide might be another option as well. Some other therapies that we can potentially try. So salicylic acid, it's kind of an aspirin derivative. It's used for many years, but there's actually not really a whole lot of studies to support this. It's a keratinolytic, so it's going to help to kind of destroy some of that skin there. You'll see it being used for some other disease states, things like warts and things like that, for that keratinolytic action. Also thought to have some mild anti-inflammatory, antimicrobial activity, but usually not going to be used for acne specifically. You can potentially use some anti-androgens, and so we'll talk about spironolactone. It's actually a diuretic that we'll talk more about in the hypertension section, but this is a potential use because it actually has some anti-androgen activity. So it can, if the acne is due to too much testosterone activity, this can help blunt that a little bit. And then for females, oral contraceptives may be useful for some of them by utilizing things like ethinyl estradiol or norethindrone ethinyl estradiol combinations. This can actually help tamp down some of their acne as well. So it's kind of, they may be on it for other reasons, and it's kind of a nice side benefit of that.
So is the hormone that's responsible for acne androgens?
Things that have androgen activity tend to worsen acne. Right, so lots of steroids may have kind of multiple actions. So even if I give like a glucocorticoid, something like a hydrocortisone, or not that so much, but like prednisone, things like that, they can have some androgen activity, right? Because it just depends on how they interact with those receptors. Yep. Yes. So yeah, those are not estrogen, or those are not androgens. Obviously, when I mention androgens, I'm meaning really testosterone, and then it gets converted to dihydrotestosterone, that DHT. By using these oral contraceptives, they kind of help to tamp down the effects of a lot of the. There's a lot of enzymes that actually convert things like estrogens over into testosterone and things like that. But this ends up having a net anti-androgen type of effect for the patient, and leads them to have less acne. Funny story, so I worked in poison control. That's where I did my fellowship in toxicology. I actually had a dad who called up one time, and kids get into stuff all the time, and they said, oh my gosh, my son, he just took one of my wife's birth controls. What am I going to do? And of course I know it's not going to do anything to the kid, but I said, listen, he's going to be just fine. But if he wants to go shopping for the next couple of days, just indulge him, okay? He didn't find that too funny in the beginning. Anywho. Actually, wouldn't be a problem if the guy took a one-time dose. So, anyway, he was worried that his son would actually turn into a girl. It's kind of funny. A lot of people don't know anything about medicine, so this is why you guys need to know about this stuff. Okay, some other things that we can potentially do for acne, intralesional steroids. So this is good if you have very large individual inflammatory nodules. Because we're applying these drugs intralesionally and locally, you're going to see less systemic absorption. You can actually end up seeing some local tissue atrophy secondary to this. So it could be one side effect there. And then usually we don't want to do oral corticosteroids for this, but sometimes low dose therapy can actually reduce symptoms if you're having a patient with really kind of high adrenal hyperactivity. This is because once the adrenal glands kind of sense there's exogenous steroids around, they kind of start to depress their own production. That's where you see that adrenal suppression that comes from that. And so, if you have a really highly inflammatory disease, this might also help as well for a short course.
So I get why you would want a corticosteroid because it's anti-inflammatory, but the previous slide said that corticosteroids could also cause your condition.
Exactly. So you kind of have to figure out, is your patient really having an overly, really hyper-inflammatory kind of condition? And if so, that's where glucocorticoids can kind of help out, because it'll kind of tamp things down a little bit and give your body a chance to kind of process things. But if you were doing it chronically, especially if I was taking chronic steroids for, say, something like if I was on a certain cancer regimen, or say I was taking it for rheumatoid arthritis, that might be a side effect I have from those, right? So these would be patients with different kind of different pathogenesis of how the acne came about in the first place, right? So these are more for patients who are have acne, it's highly inflammatory in nature, and so they need something to kind of help deal with that inflammation just for a short course in order to kind of tamp it down, and then you would kind of titrate them off of it, right? Okay. So this is a lot easier to kind of digest than what it looks like, but basically this is kind of your stepwise approach to how you would manage acne for your patients. So it can kind of be broken down to 4 different types, looking at the, with increasing severity as you go through with types. Basically this goes over exactly what we talked about, using topical agents when possible at the beginning, get away with things like benzoyl peroxide at first, and if those are not working, then starting with topical retinoids and whatnot. If those are still not working, then you're going to start to use things like systemic retinoids. You can use systemic antibiotics and whatnot. So this is just kind of give you an idea of kind of that stepwise approach you're going to take. You're going to start a patient on one type of drug, you're going to see how it works, and then if it's not working, either increase their dose, until they can't tolerate it, or switch over to a different agent, or you may add on multiple agents that will kind of work synergistically together. So it wouldn't be unreasonable to have someone who's on a benzoyl peroxide product plus say a topical antibiotic, or say a retinoid plus benzoyl peroxide or something like that. So it's not infrequent to see that. That makes sense to everyone? So you can kind of review that slide. If you have any questions, just let me know, but otherwise it's pretty straightforward. I'm not going to get super into details on, specifically, if no response after 3 to 6 months, what do you do? But basically just know kind of the stepwise flow of how that will work. Say if, if oral, actually let me say if, benzoic acid failed, what do you move on to after that? Kind of know that stepwise approach. That might be a type of question I might ask. Okay, another form of acne could be this acne rosacea. Just kind of get these, probably looks like they drink too much, but kind of have this red, reddening of the cheeks, the nose, chin, things like that. Kind of a different pathogenesis, and no one really knows the full extent to how it comes about. Usually you're going to see in older patients, so say 30 to 50. You're not really going to see any comedones. Really, they're just having this reddening of the skin. May affect women more than men, and can be triggered by different things. So if you have hot liquids, spicy foods, certainly alcohol can affect it, sunlight, heat, all things like that. So therapy is going to be much different because the pathogenesis is going to be different. So usually you're going to see that maintenance therapy will be required for these patients, and one of the new things that they're recommending for this is going to be this topical bromonidine. We'll talk more about this when we get to the ophthalmology section, talk about glaucoma, but essentially what this is an alpha-2 receptor agonist, and so it actually activates the alpha receptors within the face when applied topically, and will actually constrict those blood vessels to decrease that erythema that's happening there. So that's basically how that one's working. Other things they've tried that seem to have some efficacy include things like metronidazole gel or creams, clindamycin or erythromycin, and then for more severe cases, they may even need systemic antibiotics being administered there. So really probably bromonidine is probably the one big recommended thing, and then you try other agents if that's not working. Okay, some other random dermatologic things. So if you have lice infections, so if anyone's scratching our head over this one. So certainly you have body lice or scabies. We'll talk about pubic lice, and then also head lice. There's going to be a couple different agents we'll talk about we use to treat these. So looking at head and body lice, one of the things we can use, these are actually insecticides that we're using here. So permethrins are agents that are very selective for the bugs, basically. These are actual bugs we're talking about, arthropods here, versus bacteria. But basically they are selective for them. They can cause paralysis by inhibiting sodium influx through their neurons. So you know how neurons propagate action potentials down through sodium channel influx. By blocking that, it kind of works similar to local anesthetics, as we'll talk about later on in this class, but essentially by doing that you actually paralyze the lice and cause them to die. So you can use things like NYX 1% cream. You don't really see a whole lot of systemic effects from this. Hopefully you just apply it topically, deal with the bugs, and then you're done with the lice. Also, it's important to use things like nick combs and whatnot and make sure you actually get rid of the eggs and all that stuff. You'll see things like pyrethrins, piperonal butoxide. They're all basically just permethrin derivatives. May see some skin irritation, but for the most part, they're pretty well tolerated from that standpoint. You might see ivermectin. I don't ever see that one used too frequently. Malathion is actually one I've not ever seen used, but happens to be flammable, so don't put any flames near it. And formic acid itself could also be potentially useful, but probably see the permethrins being your primary agent for these. That are available over the counter. It's pretty easy to use. If you have scabies, there's this other agent called crotamycin. This is has really an unknown mechanism of action, but it's thought to also have some antipruritic actions as well, so it can kind of deal with a lot of the itchiness and things like that from the scabies, along with killing them off. Again, pretty well tolerated, maybe some skin irritation, but nothing big with that. For pubic lice, you have another drug called lindane. Lindane is also another type of the word insecticide. This one is important to not overuse Lindane. Lindane itself can come as a shampoo, as a lotion. This one can penetrate human skin, and unfortunately is not as selective between the insects and us as something like permethrin is. So if you overuse this drug, you can actually end up leading to seizures. This is actually a black box warning that was added to Lindane to not overuse this. So the instructions will be, say, wash once and that's it. You usually want to give it at least a few weeks before you're going to have to use this again because of the seizure risk. As far as warts go, typically these are caused by human papillomavirus. You'll see frequently that keratolytic agents are being used here. So salicylic acid is going to be one of the big ones. You can also see some other agents like podophyllum that will help to decrease the viral replication. Does anyone actually know like one of the best therapies for warts is? Duct tape. Yeah, duct tape is actually one of the big ones. They did some studies that actually compared salicylic acid versus duct tape, and duct tape worked just as well. You know, and everyone's got duct tape, right? So it really does fix everything. So you have the podophyllum, which will actually help to prevent some of the viral replication. Has some keratolytic effects as well that can be utilized. And then we also have this Imiquimod or Aldara, 5% cream. This one's actually useful for pregnant patients. It can be utilized for them since it's category B. And then actually there's a vaccine against human papillomavirus, specific types. We'll talk more about that when we get to immunizations, but Gardasil can be used and help to prevent things like cervical cancer. I don't remember, do you guys have this slide? I will send it out to you guys. I think I added it because I forgot it. But basically, Imiquimod is immunomodulator, and what it's actually doing is helping to stimulate peripheral mononuclear cells. They release things like interferon alpha, and they'll actually stimulate tumor necrosis factor alpha and interleukins. And so by doing that, you stimulate the immune system to actually help destroy some of the virus. Useful for things like basal cell carcinoma, but also some external warts and things like that. Typically, you have to apply it several times during the week, and then you'll see skin irritation in almost all patients. So this is kind of one of those prescription products you kind of go to if they fail at everything else. Again, you'll see that the more inflammation you're actually having, because you're actually inducing inflammation, the better it's working. So it's kind of a good sign of efficacy there. But just let your patients know about that. Okay, atopic dermatitis. We kind of talked a little bit about dermatitis a little bit, but some other things you can use, things like Cetaphil to help with patients with sensitive skin. We kind of talked about some of the corticosteroids and topical immunomodulators, things like Elidil and things like that. For patients who are having more weeping lesions, you actually want to dry these things out. You may see things like colloidal oatmeal that can actually help with some of this irritation. And then even aluminum subacetate or Dombro tablets. You can produce a thing called Dombro solution. When you put it in water, it can help to dry out and act as an astringent as well. Hydroxyzine, again, we'll talk more about this when we get to part of that ENT section. We're talking about oral antihistamines, but that's one you can use to help deal with some of the itching and things like that. Some pictures of dermatitis there. If you're having some dandruff or seborrheic dermatitis, usually shampoos with things like selenium are going to be pretty effective. So that's like your Head and Shoulders. Also other things like ketoconazole or tar containing solutions can be useful here. For more really severe conditions, steroids might be utilized to help kind of tamp some of that down. We'll talk more about fungal infections later, and then also herpes simplex. Let's see what else. Psoriasis, usually you're going to be seeing, this is kind of an autoimmune condition, you're going to be seeing a lot more kind of high and ultra high potency steroids being utilized for psoriasis. So typically, unless you're working like in a derm office, you probably won't be prescribing this too frequently. But utilizing these patients usually using pulse therapy for when they're having like kind of an acute flare-up of the psoriasis, and then using kind of more medium potency agents kind of for more maintenance therapy here. Also using kind of occlusive dressings will help as well to kind of help increase the kind of the exposure the skin's having to the steroids. You can also use this ointment here, this calciprotene. I don't ever say that word very often, but it's a vitamin D analog. But this one should not be used with steroids. They can also help deal with some of the inflammation that you're seeing there. Talking about tazarotene, so one of those retinoids. Let's see what else. Yeah, so there's some other things. So usually, immunosuppressants are going to really be the big therapy for psoriasis. Okay, so any questions on dermatitis? I know it was quick, but now we get to go to ophthalmology.